Hi, everyone. This is Danita Ruszkowski from Integrity Coding. This is our newest guide sheet. It is on the urinary system. So we're going to go through, as I say in the guide sheet, this is in no way an exhaustive study. I'm going to put a little light on here. This is no way an exhaustive study of the urinary system, but I've hit on the key points that I believe they're going to ask students on the exam. So I want you to take your coding book, and I am quoting from the 2020 CPT AMA edition, as you can see, hopefully. So yeah, we're changing over all the books from 2019. And people are asking, are the code sheets still good even though they were done in 2019? Yes. The principle of coding doesn't change. Some codes might get updated or revised. The principle still remains the same. So let's continue. From the 2020 book, I am on page 359. This is your table of contents for the urinary system. On the page before it, on page 358, you have a blank page here for notes. In this guide sheet package, I also gave you a sheet with 20 medical terminology questions, 20 anatomy questions, as well as your coding guide sheet. Well, that blank page is a great place to write your notes because on your national exam, they're going to ask you medical terms and they're going to ask you anatomy questions. Now, I can't guarantee you that they're all going to be in the urinary system, but there's a perfect place to have all the notes that you need. So let's continue. If you notice on page 359, it starts off by saying surgery, and then it talks about the urinary system. The urinary system is split up by the anatomical sites, just like every other portion of CPT, so follow along with me. It starts off with kidney, and then you have all of the subheadings under kidney: incision, excision, renal transplantation, introduction, repair, so on and so forth. The subheadings throughout CPT don't change. Some of them might have a little bit more, some of them a little bit less, but basically you're always going to see your incision, excision, repair, introduction. You then have ureter, and we're going to touch on that in a minute when I show you the anatomy picture. And then you have the bladder, and it goes just like our anatomy goes. Our anatomy, if you go top to bottom, the first thing you're going to see is your kidneys. Next is your ureters. We have two ureters, one on the right and one on the left. In the middle, you have your urethra. So again, two ureters, one urethra. That is how urine gets out of the body. So turn the page, and I'm also going to pull up on the screen a picture so you can see it. A picture is worth 1,000 words. I always say it. So on the screen here, you'll see it's a picture of the human anatomy. And just as we said, it's going to be impossible to understand any section of CPT if you don't have a good understanding of the anatomy of it. That's just the way it is. So look here at this picture, and it's also in your guide sheet. Here you will see your kidneys, and they look like kidney beans. They're on the right and one's on the left. You have two of them. You have two ureters, one on the right and one on the left. You have a bladder. They call it a cysto. Cysto is the medical term for bladder. So you have your urinary bladder, and then you have your urethra. Now, if you look here at the pictures of the kidneys, it shows you a picture of healthy kidneys. A lot of what you're going to be coding for in this section will be if they have somebody has kidney stones. Now, one thing I picked up on when I was studying the urinary system is some of the terms are used the same terminology that we use for the brain. The kidneys have a medulla and a cortex. But again, here is a picture of a healthy kidney. Here is a picture of a kidney that has stones. Not that I've had it, thank God, but I've heard that it's very, very painful when somebody gets kidney stones. And then you have the third picture where my cursor is when somebody has polycystic kidneys. That's numerous. Poly means many. So they have many cysts or stones within the kidneys. Okay, the next thing we're going to do, I want you to turn the page in the 2020 book. On page, first go to page 360, because the next subheading there is urethra. So again, it starts kidney, ureter, bladder, urethra, just like in our anatomy. I'm going to review that again. 2 kidneys, 2 ureters, 1 bladder, 1 urethra. All right, on page 361, the first heading that we have is kidney. It's in red. The anatomical site is in red. The subheadings are in blue. The subheadings tell what they're doing. So the subheading here that we're looking at on page 361, first one is incision. Code 50010, renal exploration, not necessitating other specific procedures. That's just when they're going in to look around to see what the problem is. This is also a good point to bring up at this juncture when we talk about therapeutic services and diagnostic services. There is a difference. Diagnostic procedures is when they are going in to diagnose a problem. Therapeutic procedures are when they already know what the problem is, now they're going to treat it. Diagnostic, therapeutic. Think of the word therapy when you think of therapeutic. Okay, I want you to look at the next code. 50040 is the next code we're going to look at. It says nephrostomy with drainage. Now, nephro, which you'll see in the medical terminology sheet that you got, nephro means kidney. Nephro means kidney. Otomy, otomy is when they create an opening. So nephro and otomy means that they were creating an opening. Why are they creating an opening? It depends on what's going on with the patient's kidney. Code 50045, nephrotomy with exploration. Code 50060, lithotomy, removal of calculus. So on the guide sheet, I broke down some of these terms. Nephro, again, is kidney. Lithotomy, we heard the word lithotripsy. That's the crushing of stones so that they dissolve and they can be removed from the patient's body, whether by a procedure or if the patient is able to expel them on their own. So nephrolithotomy, removal of calculus. When you hear the word calculus, it means kidney stone. Code 50080, percutaneous nephrostoll lithotomy or pyelostoll lithotomy. Again, you break it down simply. You see all those terms and you're like, oh, forget it. I'm done. I don't even care what they're doing. You can't do that. You have to stop and say, okay, well, what do those words mean? First of all, when you see the word percutaneous, that usually means they're approaching the patient. Percutaneous, when I hear that, I think of a needle. Percutaneous, that's a needle approach usually. And then nephrostoll lithotomy, nephro again is kidney, litho is stone, and then an ostomy. They're creating an opening to remove a stone. Also in code 50080, follow along with me. It says with or without dilation, endoscopy, lithotripsy, stenting, that's a key word there to me, stenting, or basket extraction, up to 2 centimeters. The 2 centimeters is the size of the calculus or the stone. So if they give you those dimensions, you code according to the dimension of the stone that's documented. You only code what's documented. If it's not documented, it never happened. Now, they could say that they removed a stone and they didn't give an exact measurement, then you would have to go to the lowest, which would be code 50080, because it says up to 2 centimeters, meaning it's 2 centimeters and below. So again, if they don't tell you the diameters, you don't guess at it. You say, well, I think they probably did 4. No, you don't do that. You code to the lowest, or you ask your provider what the size was. Look for some kind of a report that may have it. If not, code to the lowest dimension. All right, turn the page, please. The next subheading you have is excision. Excision is pretty self-explanatory. They're excising, they're removing something. What I want to spend a little more time on right now is renal transplantation. So if you look on page 362, in the guide sheet, I also gave you a reference. There is a YouTube video that I watched that gave me a really good understanding of renal transplantation. It's very, very good, and it's animated. It's nothing graphic. Certainly, if you think you could withstand that, I'm sure there are those kinds of videos too, but watching procedural videos will greatly enhance your coding expertise because you'll see what they're doing. It's one thing just looking at a code. It's totally different when you get a picture in your mind because you've seen it. You understand what that provider is doing, and it makes you that much more accurate as a coder because you now have the picture in your mind to code it to the highest specificity. So with renal transplantation, you have 3 different steps, 3 different, I don't want to say people, but there are 3 different components that are going on here. You have cadaver donor, you have a living donor, you have backbench work, and you have recipient. So I just mentioned 4, but point 1 in your coding guidelines talks about the cadaver donor or a living donor. Now, if somebody has a kidney transplant or any transplant for that matter, it's coming from either a cadaver, someone who has deceased, or it's coming from a living donor, somebody that's a perfect match for them. You as the coder need to make sure you're choosing the right codes, and I went over this in the guide sheet. The next step is the backbench work. Remember, even when somebody is, the donation, let's say, of this kidney is coming from somebody who's deceased, well, there is still work in removing it from that deceased body, making sure that the deceased body's remains are intact, put back, I want to say that respectfully, put back the way that God made them. And then you have the recipient. So you have a living donor, a cadaver donor, you have backbench work. That's the provider working on the person who is deceased, the removing of that organ system, and then they stitch the patient back up, the cadaver. And then you have somebody who's working on the recipient. You have to keep those steps in mind. So now let's go looking at some of the codes. Code 50300, read along with me. Donor nephrectomy. When you hear me raise my voice, that's when I'm trying to say something, give you a hint. From cadaver donor. I highlighted the word cadaver donor, and it's unilateral or bilateral, meaning it's one or both kidneys. So again, who's donating this? A cadaver donor, somebody who is deceased. Code 50320, the key word there is open from living donor. Now again, that is a child code of 50300. Those of you that are not familiar, we call them parent codes and child codes. Some other terms you may hear them is main code, indented code. Well, the main code of 50320 is code 50300. The correct way the code 50320 is read, follow along with me, is donor nephrectomy, stop. Once you see that semicolon after the parenthetical wording there of including cold preservation, stop. You then bring in the child code or the indented code. Open from living donor. So I hope that made sense. Code 50323, what step are we at here? This is the backbench work, step 2. Backbench standard preparation of cadaver donor, renal allograft prior to transplantation. The word allograft, first of all, the word allo means it goes from the same species, human to human. Auto means the self, means the patient's own body. Well, in this case, the backbench work, the patient's not giving themselves their own kidney. That's not possible. But they're doing an allograft, meaning same human to human. So that's the backbench standard preparation of, highlight the word cadaver donor. Code 50325, backbench standard preparation of what? Living donor. Easy, right? Code 50327, backbench reconstruction of living or, of cadaver or living donor, renal allograft prior to transplantation. In the video that you're going to see, it's very interesting. Remember, our body is made up of veins and arteries. Well, when they are transplanting this kidney, they're removing it, they're detaching it. So it needs to be removed. If you can, think of it like wires. When wires are being cut from one area, I hope that's a good example. Wires are being cut from one area to be placed somewhere else. So you have to cut off the circuitry from the kidneys, from where that kidney currently is. It is then going to be transplanted into the recipient, but you have to do reconnections of veins and arteries. Right here where my cursor is. There are veins and arteries attached to these kidneys. Well, they have to be reattached when they are transplanted into that living donor. And they have to be reconstructed on the patient that is giving of their kidney, whether it be a cadaver or a living donor. Okay, let's see. The next thing I want to talk about on page 363, it says renal pelvis catheter procedures. The heading, the subheading there is indwelling catheter. Look at code 50382. It says removal via snare capture and replacement. Highlight the word remove and replace of internally dwelling urethral stent via percutaneous approach. Many, if not most of these codes include, it says includes radiologic supervision and interpretation. You need to have that highlighted and underlined. I want to review that code again. It's a removal and a replacement. A removal and a replacement of what? A stent. How are they removing and replacing it? Percutaneously. It's some sort of a needle that they're using. And the radiologic supervision and interpretation is included. On the guide sheet, I made it a point to explain to you that you need to know the difference between ureter, U-R-E-T-E-R, ureter, and urethra, U-R-E-T-H. And I point out those words in red. I point out the T in red and the TH in red, because don't make the mistake that I made. I would see ureter and urethra. They look so similar in their spelling and in their pronunciation. I was getting the wrong code. Don't do that. Make sure you know the correct body area. Are you talking about your ureters or the patient's ureters, or are you talking about the urethra? Two different body parts, two different functions. Code 50384 is a removal of indwelling urethral stent. Now again, whenever I hear the word stent, I always like, well, I gotta remember that it's a stent. But notice here, it doesn't say removal and replacement, it just says removal. Code 50385, removal and replacement again, internally dwelling urethral stent. How are they doing this? Via transurethral approach. Transurethral approach. Code 50387 is your externally accessible. So 50387 reads removal and replacement of externally accessible nephroureteral catheter. So again, one is internal, the codes that we just read, that keyword should jump out at you, internal. Code 50387, the keyword that should jump out at you is external. Internal, external, and the approach that's being used to change and or remove the catheter or the stent. All right, if you turn the page 364, this is your other introduction, injection change removal procedures. Now, here's where they're going to talk about therapeutic procedures. So I want you to look at something. Code 50391, installation or installations of therapeutic agent into renal pelvis and or ureter through an established, meaning something that's already there, nephrostomy, pyelostomy, or ureterostomy tube. And then it says, for example, anti-carcinogenic or antifungal agent. This is when they're injecting the patient in order to treat whatever is going on with the patient. Make sense? All right. We're now into our repair codes on page 365. Code 50400. Pyeloplasty. Whenever you hear the word plasty, and in the guide sheet, I go over this. I always look at my suffixes when I'm looking at a medical term, because your suffix tells you what is being done. When you hear the word ectomy, that means surgical removal. When you hear the word otomy, that means creation of an opening. When you hear the word plasty, that means a surgical repair. So pyeloplasty, that means they're doing a repair. Foley wide pyeloplasty, plastic operation on renal pelvis with or without plastic operation on ureter. Nephropexy, when you hear the word pexy, that means a surgical fixation. Nephrostomy, Hyalostomy, or urethral splinting. And the word simple there should be highlighted. Are you going to know the difference between simple and complicated? With your documentation. When you're able to look and see what your provider did, you're going to be able to tell by what they did just by the documentation. You'll be able to discern if it's simple or complicated. Please turn the page. On page 366, you have your laparoscopy procedures, or depending on how you say it, laparoscopy. So under laparoscopy, which means that's when they go usually through the umbilical cord, the belly button, in order to do the procedure. So it says surgical laparoscopy always includes diagnostic laparoscopy. To report diagnostic, we just say lap, a diagnostic lap, separate procedure, use 49320. This is a really good place to talk about separate procedures because you're going to see there. One in particular we're going to talk about is when we get to the cystos. We always just abbreviate them as cystos. Well, I'll get to that code in just a minute. But when you see the word separate procedure in parentheses, be very mindful of that. Separate procedures mean that you generally cannot code for that separately. It is usually part of a more extensive procedure. And it's like part and parcel. You don't use those codes that say separate procedure unless it was done independently, documented as done independently, and you can prove it should you get a denial. You can say, oh no, see, they did this all by itself. But there are some codes you do not use with separate procedure. We're going to go over that. If you can prove that it was done independently of another procedure, yes, you can use that code and use modifier 59. That's when it's done with another procedure that you say, oh no, this had nothing to do with that procedure. We did this independently. I have to be honest, it's far and few between that insurances are going to accept that. So you make sure that you have it documented. Should they deny it, you can come back and say, see, it says it right here. So that's really going to be a payer, whether or not they agree with an insurance company. Depends on your agreement that you have with them. So let's see, code 50541, laparoscopy, surgical ablation of renal cysts. So there are various ways that you can remove cysts. You can do it with lithotripsy. You can do it with, just like they said here, laparoscopy, laparoscopy, you know what I mean. So they can remove the cyst that way as well. There's more than one way to skin a cat, so to speak, but there is more than one way to do a procedure. Code 50542, again, there's that indented code. That means it's part of the main code. So let's read that together. It goes like this. Laparoscopy, surgical, stop, because we see that semicolon. Then we bring in the child code. Ablation of renal mass, lesion or lesions, including intraoperative ultrasound guidance and monitoring when performed. When you hear the word when, no, that also means if. If they do that, then yeah, it's included. Okay, so when they say when, it also means if. All right. Let's go to code 50590. This is your lithotripsy. This is when they go in and they crush those stones. Code 50590, lithotripsy, extracorporeal shock wave. It's really a shock wave that goes in and breaks that stone apart. 50592, ablation, one or more renal tumors percutaneous. Code 50593, ablation, renal tumors, unilateral percutaneous cryotherapy. When you look at codes, and I know it because I do this for a living, and I know myself being a student, sometimes codes just they start to look the same. When you're starting to get that and your eyes are starting to get tired, stop and either step away and then come back and reread those codes. Okay, wait a minute, they look the exact same to me. Well, let's examine 50592 as compared to 50593. Well, first of all, yep, they both say ablation. One is of, 50592 says one or more renal tumors. One says renal tumors unilateral. And then one says percutaneous. But notice 50592 and 50593 have two different ways that they're doing this. Can you pick out how they're doing it? In 50592, it's done by radiofrequency. Highlight that, radiofrequency. In 50593, it's done by cryotherapy. You have lots of parenthetical notes in this section. You know how I feel about parenthetical notes. The way I was taught them, they're do not codes. So when you look at those parenthetical notes and it says do not code, that in itself is still a coding guideline. You need to pay attention to that because more often than not, especially those of you training for your AAPC exam, whether it be the CPC or the COC, or maybe it's your urology specialty, those do not codes may help you do a process of elimination because they may include one of those codes in your answer. And when you know it says do not code this with that, you know it's wrong. You can eliminate it. Okay, on page 368, you have your ureter. That's the next heading that we're in, ureter. Again, incision, excision, introduction, repair. Do you see the pattern? I always teach students, and you've heard me if you've heard any of the other teachings, I always teach students that there is a pattern all throughout ICD-10 and CPT. You know how I learned that? When I wasn't passing my exam. I said there has to be, it's like cracking the code. I said, I gotta try to figure out a way, I call it mapping. When you start to see, well, this code is here, and then the next one is this, and then the next one is that. There is a pattern. Nothing changes in CPT. The main heading is your anatomical site, and then underneath that is what's being done within that site. So again, we have incision. The difference here under bladder, we have incision, then it says biopsy. And again, we have the next heading, subheading excision and introduction. Okay, on page 373, you have urodynamics. Urodynamics is when they want to go in and measure a patient's urine output. Sometimes patients have an overactive bladder. Sometimes there's a stricture. So they do these urodynamic studies to measure that. So let's read these coding guidelines together on page 373. It says the following section, sections 51725 through 51798 lists procedures that may be used separately or, I like the word or, in many and varied combinations. When multiple procedures are performed in the same investigative session, highlight, modifier 51 should be employed. All procedures in this section imply that these services are performed by or under the direct supervision of a physician or other qualified healthcare professional and that all instruments, equipment, fluids, gases, probes, catheters, technicians' fees, medications, gloves, trays, tubing, and other sterile supply be provided by that individual. When the individual only interprets the results and/or operates the equipment, a professional component, highlight this, modifier 26 should be used to identify these. Modifier 26 is used for the professional component. What does that mean, professional? It means the professional doing this procedure. TC is the technical. So if a provider is doing one of these procedures and yet somebody else is going to interpret it, you have to make sure that your procedure has the correct modifier on it so that everybody gets their fair share of reimbursement. Modifier 26, again, is the professional component. Modifier TC is the technical component. When it's done in an office setting and the provider both owns the equipment and does the interpretation of that test, you don't need to split it. They get all of that reimbursement and no modifier 26 or TC is needed. Okay, here we go. Here's one very important in this section. The guide sheet goes over it. On page 374, it says endoscopy, cystoscopy, urethroscopy, cystourethropy. Now listen to these guidelines. They're really important. It's going to help you do a process of elimination. Endoscopic descriptions are listed so that the main procedure can be identified without having to list all the minor related functions performed at the same time. For example, what minor procedures? Then it says, for example, mediotomy. That means mediotomy is when that has to do with the male urinary system, when a male has a problem with urinating. Urethral calibration, that's to do with the female anatomy, when a female has a problem with their urinary system. And or dilation, urethroscopy, and cystoscopy, highlight that, prior to transurethral resection of prostate, meaning the male, ureteral catheterization, following extraction of ureteral calculus, internal urethrotomy, and bladder neck fulguration when performed, a cystoscopy for the female urethral syndrome, when the secondary procedure requires significant additional time and effort, it may be identified by the addition of modifier 22. For example, urethrotomy performed for a documented pre-existing stricture or bladder neck contracture. Because continuous urinary diversions utilizing ileum or colon serve as functional replacements of a native bladder, endoscopy of such bowel segments, as well as performance of secondary procedures can be captured by using the cystourethropy codes. For example, endoscopy of ileal loop with removal of ureteral calculus would be coded as cystourethropy, including ureteral catheterization with removal of ureteral calculus 52320. In other words, they captured everything that was done in that example with one code, 52320. So look at that with me. 52320 reads, I just saw it, reads, it's on page 376 in the 2020 professional edition, Cystourethropy, including urethral catheterization with removal of urinal calculus. In other words, what that guideline is saying is be very careful what you code. Don't overcode, don't upcode, because it does it. Number one, insurance won't pay it. Number two, you're not following the coding guidelines if you are. If the cystoscopy is and I'm going to say it in Italian terms, it's like a gimme. That's something that they're going to be doing when they're doing certain procedures in the ureteral system. Generally speaking, you don't code for the cystoscopy separately because they need to do that. That's part of the procedure. But if you look at code 52000, cystourethropy, it says separate procedure, doesn't it? And as I tell you in the guide sheet, does that mean you can never use it on its own? No, you certainly can use it on its own. If a patient comes into the office just to have a cystoscopy done, yes, that's all they're having done. What other code could you use? So yes, you can use that 52000. But if they have another main procedure, and while they're there saying, no, we're going to do a cystoscopy too, let's make sure everything that we've done to help this patient, that the systems are flowing, so to speak. Well, they're going to have to do a cystoscopy to check that. You don't code for it separately. I hope that makes sense for you. 1 second. Just want to check something, everybody. Okay, let's continue. So we talked about cystoscopies, urethroscopies, cystourethropscopies. We talked about your main terms to look at. We talked about the fact that when you're doing a significant procedure and they said, oh yeah, we did a cystoscopy too, don't code for it. It's included in that main procedure, usually, unless you can prove that it was done independently of something that's not related to the urinary system. All right. Now we're going to talk about, there's another really good coding guide, not a really good coding guidelines, but all guidelines. Integrity coding is about coding guidelines. Our students score so well on their exam because we really drill into them the importance of when you're going over work, when you're going over scenarios and homework, you want to be able to prove it. I ask my students, I want you to show me that through the coding guidelines. And if you get a question wrong, which is great, we love it when students get questions wrong because that's a great opportunity. We see errors as opportunity. Then they can learn by going back to the coding guidelines. All right, so on page 376, it talks about the ureter and the pelvis. Ureter and pelvis. Read along with me. What's the first word? Therapeutic. Highlight that word. Therapeutic urethropscopy always includes diagnostic cystourethropscopy. To report a diagnostic cystourethropscopy, use code 52000. Notice it says when to use it. When it's diagnostic, they're checking for a problem, not going to treat a problem. I want you to get that. When do you code for diagnostic cysto? When you're checking to see, is everything okay? Diagnostic, not the therapeutic. Therapeutic cystourethropscopies with urethroscopies and or pyeloscopies always includes diagnostic cystourethropscopies with ureteroscopies and all pyeloscopies. To report a diagnostic cystourethropscopy with ureteroscopy and or pyeloscopy, use 52351. So what would you do after reading that? You don't quite understand it? Look at code 52351. You'll see, again, it encompasses everything that was done with one code. Do not report 52351 in conjunction with 53444 through 53446, 52352 through 52356. The insertion, and I have asterisks around this, next guideline, the insertion and removal of a temporary, not indwelling, but temporary, urethral catheter during a diagnostic or therapeutic cystourethropy with ureteroscopy and or pyeloscopy is what? It's included. Included means bundled. Bundled equals don't unbundle it. Don't code separately. It's included in 52320 through 52356 and should not, whenever they say the word should not, that's like a parent telling a child, do not do this. Why? Because I'm watching out for you. You don't necessarily need to understand why. I'm telling you, I'm watching out for you, and I'm telling you that can harm you. Should not be reported separately. To report insertion of self-retaining indwelling stent performed during diagnostic or therapeutic cystourethropy with ureteroscopy and or pyeloscopy, report 52332, in addition to the primary procedure. The difference, it looks like what they're talking about is, are they talking about an indwelling stent removal? Yes, an indwelling stent, as opposed to the previous coding guideline where it says the insertion and removal of a temporary urethral catheter, not stent, catheter, excuse me. That's the other difference too. Go to the paragraph before. It starts with the insertion and removal of a temporary urethral catheter, not stent, my error, catheter. The next paragraph says, to report insertion of a self-retaining indwelling stent performed during a diagnostic or therapeutic cystourethropy with ureteroscopy and or pyeloscopy, report 52332, in addition to the primary procedure performed. And it gives you all those codes. And append modifier 51. Codes 52332 is used to report a unilateral procedure unless otherwise specified. For bilateral insertion of self-retaining indwelling urethral stents, use code 52332 and append modifier 50. 50 stands for bilateral. To report cystourethropy removal of self-retaining indwelling urethral stent, see 52310, 52315, and append modifier 58 if appropriate. In summarizing those guidelines, they're talking about whether it be a catheter or a stent, whether it be something that's indwelling inside the patient's body, or if it's temporary, then it can be removed fairly easy. Again, what's going to give you the clue? The word catheter or stent. Catheter tends to be temporary. A stent is something, even the word that sounds like a stent, that sounds something more permanent, indwelling. They're telling you in these guidelines when you can code the stent or the catheter separately, or if it is bundled into those procedures dealing with the ureter and the pelvis. So that is about it. Again, the guide sheet is not exhaustive, but honestly, the urinary system is not very difficult if you understand, first of all, the anatomy of the urinary system. So let's go back a little bit. You have kidneys, and I told you that these kidneys have veins and arteries that they are attached to. 2 kidneys, 2 ureters, 1 bladder, 1 urethra. Know the difference. Watch out when you're seeing and you're doing your highlighting for ureter and urethra. Go over the medical terms that I gave you in this guide sheet. Go over the anatomy that I gave you in this guide sheet. Again, what does coding always come down to? Coding guidelines. Coding guidelines. Know the difference between a catheter and a stent. What makes one temporary and one permanent? We talked about renal transplants, how there's 3 portions of this. There is the donor, whether they be the living donor or a cadaver. There is backbench work, means that's the repair. Somebody is removing a kidney to transplant it into that recipient. But there's still work that needs to be done. They have to do, if you please excuse the term, they have to do reconnection. So they're disconnecting it from their donor. They're reconnecting those veins, those arteries, to the recipient. Well, the provider needs to get credit for that. So we call that the backbench work. And then you have somebody who's working directly with the recipient. Watch your codes when they're talking about living donor or cadaver. We talked about lithotripsy, how that's the crushing of stones. They don't always do it with lithotripsy. Sometimes they do it laparoscopy, that they go in and they do an ablation. So again, watch the approach. Laparoscopy is the approach. Remember, it's done, that means through, they make a small incision through the umbilicus, the belly button. We talked about cysto codes, the 52000. When can you code for it and when can you not? We talked about the pattern throughout urinary coding. You have your main headings: kidneys, bladder, kidneys, ureter. I want to go through it again. Kidneys. Then you go to ureter. Then you go to bladder. And then you go to urethra. Know the terminology that they're saying. Know when you're talking about the male anatomy as opposed to the female anatomy. Remember, I told you in some of the urodynamics and cysto studies, more so the endoscopies, the cysto urethroskopies. Oh my gosh, that word. Mediotomy is when they're dealing with the male urinary system. When they're talking about they wanted to measure and do some dilations with the ureters. I'll tell you the exact term that they used. When they want to do a urethral calibration, it's usually talking about the female. They do the ureters. They want to take measurements. We also talked about, cystourethroskopies. That's really about it. The difference between, here's a good code. Not a good code, something I want you to look at. My students get this a lot. I want you to look at code 52648. 52648 in 2020, it's on page 378. It says laser vaporization. Sometimes they say the word green light laser vaporization of prostate. Obviously, when they say the word prostate, you know you're talking about the male anatomy. It says including control of postoperative bleeding, complete vasectomy, mediotomy, cystourethroskopy, ureteral calibration, and or dilation, internal urotomy, urethrotomy, and transurethral resection of prostate, included if performed. I also said the word, watch when they say the word if, it can mean, or when they say when performed, it could also mean if performed. So again, laser vaporization, sometimes you'll hear the word green light, laser vaporization. Okay, so that is it for our urinary system. Not very difficult. Go over this video again, go over the guide sheet, and you won't have any problem coding the urinary system. Thank you very much for purchasing the guide sheet. And for more information and you want our other guide sheet packages, you can go to integritycoding.com and you can hit the word resource. Thank you very much. Bye-bye.